Well, good morning, everyone, and thanks for coming on a relatively chilly Friday morning. It's very obvious Dr. Page is out of town today, and so I'm very honored to be able to present our Grand Round speaker, Dr. Jim Sosman. So Dr. Sosman is on faculty in general medicine. He's a full professor, which is why I'm able to present him today. He went to medical school at University of Chicago. He did his residency and chief here at Stanford. He is the medical director of our HIV clinic here at UW Health, and he has been that for many years. And he's also the head of the Scholars Division in General Internal Medicine. And I told Jim I would be brief in highlighting his great and numerous things. And so here is the list of the great things. He has received numerous awards, and most recently in 2015, he received the Faculty Excellence Award for Research in General Internal Medicine. He travels the world truly talking about HIV. He has done 87 national presentations and over 20 international presentations in his work on HIV. He has over 56 publications on his work in HIV, and today he will be talking about HIV, the future of healthcare, getting to ground zero in HIV. He's been continuously funded in a CHS track professor position for over 20 years. And that includes being funded as a PI on a HRSA grant, and that HRSA grant is the Midwest AIDS Training and Education Center, also called MATEC. He recently received a 4-year extension through 2020, which is awesome. He's also the PI for the Ryan White grant. I would say, as his division head, that Jim is Mr. HIV, but we talk about the triple threat here at UW Health, and we don't have that many people who are in active triple threat, and Jim is one of those people. He's a clinician in general medicine and HIV and is excellent. He has a continuity clinic and is a mentor for our residents, and he is brilliant in research. And with that, he's super humble. And my story about his humility is we have a leadership meeting every Wednesday morning for the leadership team in general medicine, and I got a little note from him, and it might have been Wednesday morning or Tuesday afternoon that he wasn't going to come to the required meeting. He said, because I am at the White House meeting with the president about my work in HIV. So, many people would advertise that ahead of time and talk to Reuben about, putting that in vital signs, which we did do after the fact, but that really just is about who he is. And so I'm very honored Jim had talked to us about HIV.
Betsy, thank you for that kind introduction. Too bad my family isn't here to hear all those things. They keep me pretty well grounded. So today I'm not actually gonna talk about my direct research funding, but really about policy. And I wanted to give you folks, faculty and staff here, kind of a snapshot. Where are we in February of 2016? And really juxtapose the state of HIV, both in the United States, but really compare that with what's going on globally, because we can learn a lot from our global partners. It's not like just the education and policy exchange is a one-way vector, not at all, and I think you'll see this. And really review kind of national and global goals of care and prevention around HIV, efforts to address those gaps, and then outline kind of where we're heading in terms of future directions around this. And gotta talk about Osler, even though I didn't have anything to do with Hopkins. We all know he's kind of our figurative father as a clinician, humanitarian, and teacher, and had so many quotes. And one that always resonated, I remember hearing as a second or third year medical student, is, "He who knows syphilis knows medicine." It seemed rather obtuse at the time. Now, 30 years later for me, no, it kind of resonates. And I think if Osler, this was probably a quote of his at least 100 years ago. If he was here today, you can see I'm far less eloquent than he was. AIDS changed everything. That might be a quote of his, or at least capture the essence, which I think you'll see, which how much it has changed, not just the research realm, our ability to disseminate novel interventions and treatments, but also how it's affected the global, the whole idea of global health really grew up through HIV and the goals that we set. Remember, 15 years ago when we started seeing tremendous strides in antiretroviral therapy, the issue was, well, we know it's in Africa, but listen, they don't have clean water, potable water. How are we going to give them antiretroviral therapy? And the real change was, well, we're going to give them antiretroviral therapy and they're going to get clean water. And it's really changed everything. With that, we'll get a little more sobering. These are the latest statistics that UN AIDS puts out. We think there's about 37 million people globally living with HIV. Not a surprise, most are in sub-Saharan Africa, but certainly Latin America, Asia, every continent, every country has been affected. China, we don't get the best reporting, but we know there's a tremendous number of people affected. To this point, we believe there's been about 40 million people that have died from HIV through the last 30 years when we started recognizing this. So getting to zero, it may be a while, but we're making progress. Again, 37 million people living. With HIV, we estimate that there's about 2 million people that die of HIV/AIDS every year. This is far less than it was 10 years ago. That's improvement, but we've got room to go. About 1.2 million new infections every year, about 1.2 million deaths every year. And obviously, there's been great strides in understanding the immunology of viral infections, even how to measure viral infections. All of those kind of tangential and parallel advances that AIDS research has fostered really make us closer to an effective vaccine, but it's going to be a ways away. With each forward progress step, we kind of take a step back. It's been tough to come up with a preventive vaccine. So what does that mean? 1.2 million new infections a year globally. This is kind of how it looks. 5,600 infections a day globally. The vast majority in low and middle income countries, which you would not be surprised. And the vast majority of all of these in sub-Saharan Africa. A lot of this has to do with the fact that primate diversity, we evolved in that area, the Rift Valley, near Kenya, Tanzania, and Uganda, Rwanda. That's where primates, human and non-human primates, evolved. So virus transmission in that area has been going back millennial time periods. In fact, Tony Goldberg and a number of researchers on campus really study that interaction today with David O'Connor, Tom Friedrich. They were actually just in the news for Zika, but they really look at what's going on in the Rift Valley. Regardless, we still have children under age 15 getting HIV, and of the adults, 5,000 of these 5,600, almost 48% are in women. So outside of the snapshot that you'll see, I'll reiterate what's happening in the United States and Western Europe about who's getting HIV. Globally, this is heterosexual, and women are more at risk than men. Why is that? Because it's a sexually transmitted infection, and women biologically are always predominantly more affected and more vulnerable to sexually transmitted infections than men, based on human anatomy. Likewise, young people are getting infected and affected. In the U.S., every community's been affected, and there are geographic differences now in the U.S. Areas of the Southeast, certainly every urban center is heavily affected by HIV, but then when we look a little further, we see, this is like the South. You might look at this as remember learning about the stroke belt or other healthcare disparities, whether it's hypertension and diabetes, obesity. Well, obesity is hitting everywhere now, but this same part of the US is overly represented with HIV, probably having to do with health disparities, access to care, and other things that are disparate. In the US, we believe there's a little over 1.1 million people living with HIV. So you can see far less than 5%, a few percent of the global burden, the 37 million globally. And in the US, people of color are well overrepresented, unfortunately. In fact, for an African American man, the prevalence of HIV is upwards of about 3%, 1 to 3%. And I'm not talking about African American men in inner city Chicago, the South Side, where I went to med school, or Baltimore, where we know, or even Washington, D.C., where we know there's tremendous differences in health disparities and risks among people of color in that setting. I'm talking, these are national numbers. So nationally, we're looking at, 3% of African American men may have HIV. Those are really, really horrendous numbers. Of the new infections, we still think there's about 50,000 a year. It looks like it may be declining. About 10 years ago, we used to say 55,000 new infections, so maybe a little dip in the new infections. Most are happening in young people. The majority in the US are in men who have sex with men. Very different than in sub-Saharan Africa or even the global picture of HIV. But women are accounting for more, and we've actually made strides. This can look good or bad, that people with HIV unaware of their HIV infection has dropped to about 13%. So about 86% of people in the US, we believe, that have HIV know that. And that's better. 10 years ago, when the CDC came out with their recommendation in 2006 that all American adults between, I think it was like something like 16 or 18 and 65 know their status, we estimated that about 25 to 30% of people with HIV did not know their status. And now if you talk to people at the CDC like Bernie Branson, who helped write that policy, he would say that there's been something like 50 plus million tests, HIV tests, antibody tests performed in the US. So we're doing more testing. We're not hitting everybody, but we've made progress. And then just to underscore that about who's getting infected in the US, this is CDC data from the last decade. It's really predominantly men who have sex with men in the US. Not all, but certainly predominantly. And of that group, they account for most, 80+% of the male HIV infections, new infections in the US. Likewise, men who have sex with men that are younger and of color, Hispanic, African American, are at extremely high risk. So it's we've got room to improve on our numbers. Now let's look a little bit globally, and I'm going to compare this to what we're seeing in the U.S. And this is the care continuum or care cascade, and now you're seeing this type of model for other health issues when there are disparities involved, whether it's diabetes, hypertension, cancers. This happens to be around HIV, and this is a global picture. So if we figure there's about 37 million HIV-infected folks in the world today living with HIV, we think only about 50% are detected, that they know that. That differs quite a bit. This gap is quite different than in the US, where we think 86% of the folks living with HIV in the US do know their status. However, once we get here, this is really actually a landmark. Of those diagnosed, the majority, 15 of the 19.8 million, are now receiving antiretroviral therapy globally. This has been a landmark accomplishment. In fact, there were Public Health Service, World Health Organization, UNAIDS puts out these clever slogans. One was 15 by 15, meaning it was goal set probably in 2010, meaning let's get 15 million people that are eligible for HIV care in the world on therapy, antiretrovirals, by 2015. And those are usually, I don't know if I'd call them pipe dreams, but they're goals and very high thresholds, and we achieved it. It's really monumental. So this is the global picture, and then of those that are virally suppressed, meaning achieving the maximal benefit of therapy, you can see a little bit less, but still pretty good at about 32% of the total. Now let's look at the US. And obviously of the 1.1 million, 86% no, and a very high, we put a lot of our resource, federal funding from HRSA and state and public interest groups into linkage to care, from that diagnosis to linking them. And we do a pretty good job in the US. These are global numbers, not local. However, big drop off, as you can see, in linking them to really what we might call engaging them in care and keeping them active. You could see, if you remember what I just showed, globally, they actually have more of a problem getting everybody tested. Once they're tested, then that difference from one continuum point on the slide to the next is a little shallower. That slope is a little shallower, where here we get a big drop off in trying to link, engage, and re-engage people. Once we get them on therapy, we do pretty well in terms of viral suppression because the therapies are so effective. However, look at this, 30% of the total burden of HIV infected folks in the US are getting the maximal benefit of therapy. I just showed you the global picture and it was 32%. So, and that's taking in low, middle, and high income countries. And remember, we're only like less than 5% of the global issue in HIV, and we have, far much more of the resource. So ironically, in sub-Saharan Africa, in a village in Uganda, they do better than us. So how about advances with that sobering? This has really been monumental. Historically, probably folks that were around World War II or after with the age of antibiotics, they could, when penicillin was developed and marketed, we know it treated everything, now it treats almost nothing, but that was really a heyday. Today, or at least the last 20 years, where most of these antiretrovirals were developed and came to market, now we have 27 different antiretrovirals that are FDA approved. These aren't in the pipeline. These are already available. And we have more that are co-formulated, combination pills I didn't put up here. And some of these will look familiar to you. Some are older. We don't use a lot of AZT anymore. We don't use a lot of stabudine or D4T anymore, or DDI. They're still available. I don't think I've written a prescription too recently for them, but they still work. And usually, and as you'll see here, just looking at the life cycle, which we understand quite effectively, we probably know more about this virus than any other viral pathogen, but it still circumvents what we do. And the virus attacks CD4 lymphocytes at the T cell or CD4 marker, and then the targets that have been successful have really been reverse transcriptase that converts its RNA into complementary DNA, and AZT class medicines have been very effective in chain terminating this enzyme, the reverse transcriptase, and covalently bonding. I mean, it really does knock that out. And this was our first effort. And then our second major breakthrough about 20 years ago in 1996 was the introduction of protease inhibitors. And then adding a protease inhibitor which blocks the cleavage of protein into viable viral particles. Really, when we added that to what we had, and it was really as simple as that. We didn't have much, so we added it. It's probably like the early days of treatments of lymphoma back 50 years ago. You had what you had, and you added them together, and great, they worked. Were highly effective. Now we have fusion inhibitors here, which are still a little premature, not quite, they're available, but usually not first line, but integrase inhibitor, which integrates the proviral DNA into the host genome, has been highly effective. And now there's an array of those that we are using. So of this list, you know, whenever I talk, you know, obviously of the 3 or 4 drug combinations you could make up there, there's probably over 100. Most have not been tested, but it's surprisingly robust. Even 2 or 3 in the same category surprisingly can suppress the virus. Now, why don't we do that? Well, there could be overlapping toxicity, is usually the rate-limiting step. And then here we are, you know, 20 years later in this progression, we've had enough clinical trials to really sort out and differentiate some of these. But we still use an NRTI, or nucleoside reverse transcriptase backbone of 2 medicines, usually tenofovir and emtricitabine, but sometimes abacavir and lamivudine. And we combine it either with a dual boosted protease inhibitor. The boosting is really a PK or pharmacokinetic enhancer, or now an integrase inhibitor. That's really what's happened. But we have non-nucleosides and others to add to that mix if needed. So how successful has this been? It's really, these are more projection data based on modeling. But these model data of what we might expect in the United States, resource-rich area, or Finland, or maybe Sweden, where we know they're resource-rich and everyone gets health care, is a model such as this, meaning where from these are different age cohorts, but for a 20-year-old in 2010 that, for example, was diagnosed, might have just gotten a new infection, going to start antiretroviral therapy, we might expect an additional 55 plus years of life expectancy. That's very close to normal life expectancy. There are differences, without a doubt. And if we look at this based on gender, socioeconomics, ethnicity, there's big differences. However, this is monumental. So now the idea of HIV being a chronic condition, this is the kind of model data based on today's therapies, not even future therapies, that we're guesstimating, where someone can live a pretty normal life expectancy. You know, it might be 10 years less, but, you know, some of our folks that study rheumatic diseases, I mean, rheumatoid arthritis, you don't get a full, you know, maybe today, but 15 years ago, someone with RA, you know, they're not going to live a 20-year-old an additional 60 years, or diabetic. Well, HIV is really rivaling kind of that in developed nations. So where are we with therapies and what's happened? I'll just give you a few comments and a few studies that show you kind of where we're at today, because even though we've had these, we're modeling success, we're still making surprisingly effective improvements. And this is one which was called the START study, which is really strategic timing of the antiretroviral treatment. It was an international study of almost 5,000 people that were randomized. So they all had a CD4 count over 500, and they were randomized to starting antiretroviral therapy then, or waiting until they dropped to below 500. That's not too much of a drop, and that's really, you know, usually we would always classically think people that have just under 500, just not under the normal standard deviation for a normal range of CD4 cells, that they really wouldn't be symptomatic. Well, now with the power of these large studies, we did this randomization in 35 countries. It was phase 4 open label, and the endpoint was a major outcome, serious AIDS-defining illnesses, or any non-AIDS defining illness that's serious, like cardiovascular disease, end-stage renal disease, decompensated liver disease, and even non-AIDS defining cancers, not just primary CNS lymphoma, but really prostate cancer or lung cancer or breast cancer. And what they showed in this study, surprisingly, remember, we're going to start therapy right away above 500 or just below 500, not wait until 200, or they have defined, obvious immunodeficiency. And what we found is those that had deferred the initiation until the CD4 count just dropped below that normal range, we could differentiate outcomes. And it was actually quite effective. Though there weren't many patients that had those outcomes, 42 patients had a serious outcome in the in the immediate, and 96 in the non-deferred, the deferred realm, but that's almost a 60% reduction. In fact, it was so persuasive that the disease in May monitoring board basically said, we got to stop the trial and release data from this, because really it showed that this was highly effective. In fact, interestingly, from initiation, the initial CD4 count when people were enrolled before randomization was about 650, and it took about 3 years for them to fall to below 500 on average. And then what happened is the average time of initiation in those that were on the deferred group was around 400 cells per microliter. So again, I wouldn't expect us to find many outcomes or a statistical significant difference, but lo and behold, we did. Likewise, when we look at cancers, both AIDS-defining and non-AIDS-defining, in the immediate versus the deferred, we see higher cancer rates, statistically significant. Now again, these aren't a lot of cancers over the time period of 5,000 people that are randomized, but these are significant. That was one major, and this really was published in New England Journal this past year, so very recent. The other is the Temprano study, which is somewhat analogous in Africa. So this was not done in a mix of 35 countries. It was done mostly in the Ivory Coast, multi-center, 2x2 factorial. So they took patients with high CD4 counts, and they likewise randomized them to one of 4 groups. And this was open label. Either they were going to get immediate antiretroviral therapy, they were going to wait until the CD4 count dropped to below the World Health Organization recommendation, which was a bit of a moving target, but until their CD4 count was low, and certainly lower than 500, that normal gap. And those people would then start therapy. They would be the deferred group. And we also randomized them to one of immediate antiretroviral therapy and isoniazid preventive therapy. TB is the #1 complication of HIV globally. Not in the US, but globally, it's a big deal. Someone with TB, outside of the US, we're going to screen them in the US. We just kind of assume that they have HIV. So they were getting immediate antiretroviral therapy and isoniazid therapy, or deferred antiretroviral therapy, but still immediate isoniazid therapy. So these 4 groups and they were looking for hard outcomes of AIDS-defining illness, and they were actually able to show a difference in the number of serious AIDS outcomes or death. And obviously the group that got immediate antiretroviral therapy and isoniazid therapy concurrently did the best, and that group that got deferred antiretroviral therapy without isoniazid did the worst. Not big numbers, but statistically significant numbers. So this data also got presented this past summer and now is in press and in publication in the New England Journal. Both of these were game changers. So very quickly, our Department of Health and Human Services guidelines modified based on this. Now we recommend antiretroviral therapy for all HIV infected, regardless of CD4 count. And they give it an A1 recommendation. Now again, this is DHHS, this isn't the US Preventive Services Task Force. However, likewise, they said that it is also recommended independently they outline this as a risk reduction modality, meaning treatment as prevention. And they also give that mostly an A1 recommendation. So that's a big change. Now, as soon as we can re-engage someone in care, if they're ready for treatment based on their life, what's going on, their ability to take treatment, we give it, regardless of CD4 count. And this is what's happened in this past year globally. Obviously, our European colleagues quickly came on and agreed, let's initiate antiretroviral therapy regardless of CD4 count, meaning even folks with CD4 count above 500. And this is obviously our DHHS, but the International AIDS Society in the US also came through with this. And amazingly, in September, the World Health Organization came through with this. And they set policy and guidelines for how global AIDS funds are worked, and really recommendations to low and middle income countries about when they should start therapy. Doesn't mean that those countries are necessarily doing that, but theoretically those outcomes are going to be tied to global financial services that go to them to underwrite this. So this is really monumental and pretty much right off the press. The other thing that's happened, as I mentioned, is integrase inhibitors. This just shows one integrase inhibitor combination called raltegravir was compared to what has been the gold standard treatment for probably 10 years, which is an efavirenz-based treatment. It goes by a brand name, Sostiva. It's co-formulated in Atripla. I'm probably not supposed to use those brand names, but that's how you might recognize it. And that's really been the first one pill once a day regimen. It's not just that it was convenient, but it was highly efficacious. And everything that's come on in the last 10 years has always been mostly a non-inferiority study. Can we do as well as an efavirenz-based regimen, the non-nucleoside? Well, raltegravir being the first of the integrase inhibitors, a new class, we compared in a non-inferiority study to an efavirenz-based study, and it did better. It wasn't modeled to see an improvement, but it did better. We then followed that up with a very clever named study called Flamingo, and this was looking at a different integrase inhibitor called dolutegravir, and it was combined again with two NRTIs, probably, as you can see here, tenofovir emtricitabine or abacavir lamivudine, and it was compared to actually what we thought was very potent. In this study, we weren't comparing it to efavirenz. It was compared to a boosted protease inhibitor, darunavir, which we really thought was probably the most potent combination. That was what we thought, with the same NRTIs. And lo and behold, at 48, 96 weeks, there was an improvement, and the dolutegravir did better in this case, in terms of viral suppression, adverse events, and it was really regardless of which NRTI backbone, meaning AZT class, like tenofovir or abacavir based, didn't matter. These were a big deal. Unexpected. I certainly didn't expect it. And very quickly, again, a little over 6 months ago, the DHHS changed their first-line treatment. And it really is a landmark change from mostly the last 10 years, which really had always had efavirenz-based regimen as pretty much the gold standard with protease inhibitors. Now, the preferred first-line treatments in the US are dolutegravir with various combinations, or co-formulated, where you see the hash lines, it's co-formulated. Elvitegravir, a different integrase, or raltegravir. We likewise still do keep the darunavir up there, boosted darunavir combination, but these are it. And the efavirenz-based is now alternative. Does that mean efavirenz-based regimen isn't good? No. It's just now we have treatments that might be a little better, and most of the benefit is really in reduction in some of the toxicity. 10 years ago, the toxicity we saw and thought we were seeing from efavirenz-based regimens might have been disturbed dreams, some irritability, maybe a little bit of depression. But we would have, at the time, we would have taken that over diarrhea, 20 pills a day, nausea, fatigue, any day. Today, 10 years later, now those same side effects are enough rate limiting because we have new and improved regimens. So it's really probably that. Do I still have folks on efavirenz-based regimens? Yes. Am I switching them? Only if they have a side effect. It's really quite potent and safe in terms of other toxicities of antiretrovirals. So, but this is still a big breakthrough. So you just heard, now we're starting people sooner. So when we look at the US or global picture, yeah, we've got 30% of people suppressed. Now we really want to get everybody, regardless of their CD4 count. And we do a pretty good job of diagnosis. When we get folks on treatment, we get a pretty good job of getting their virus suppressed because these treatments are so effective. And I think, obviously through my experience, quite user-friendly. However, we really fail in some of these other things. And these are not unique to HIV, it's just we've studied them very well in HIV. And I'm sure people that study the epidemiology and the issues, disparities in diabetes could come up with similar models, but we've done it more in HIV. And these real issues of linkage to care, retention, and re-engagement, more and more of our programmatic healthcare dollars that we get federally are really channeled into that. In fact, now we have a half a dozen social work case managers to manage our cohort of roughly 1,000 patients. That model doesn't exist anywhere else in UW Health. Geriatrics, we know that they have very complex patients with a lot of needs. They might have a half a dozen social workers, but they're not managing that in only 1,000 patients. So we have a model of patient number to social work that's really extraordinary, and we need more because of what outcomes in terms of our re-engagement and linkage needs of some of our patients are so great. And this just shows you along that lines, when we look at outcomes, and this is national US data that's relatively recent, of viral suppression from the time of diagnosis. These curves differ, and actually the lower curve is the better curve. Those people are more quickly reaching viral suppression if they're engaged in care within 3 months of diagnosis. That's okay. Now our targets are a little better than that, but that's, we do see a significant difference in viral suppression. And that theoretically should downstream lead to better health care and certainly lower transmission risk. So how about some of these advances in prevention, which is really an important thing. And it really started with this, what seems entirely intuitive, but at the time was landmark by Tom Quinn and the group at Hopkins, along with the Study Center in Rakai, Uganda. And they looked at, in the last more than a decade ago, this came out 16 years ago, in a Rakai cohort in Uganda of serodiscordant heterosexual couples. A little over 400 were, and they basically looked at viral loads and transmission between couples. And they really showed that the higher the viral load, the viral burden, so to speak, in the serum, the higher the risk of transmitting to their seronegative partner. Seems very obvious today, but it really wasn't then. And this was really a proof of concept. And based on this, many of our modern contemporary biomedical prevention modalities really all trickle from that. I'm going to talk for a moment about heterosexual couples in this vein. And again, as I mentioned earlier, the world burden of HIV, the biggest risk is to women. And to tell you the truth, unfortunately, in women within sub-Saharan Africa, married women, and you know, we know that the age of consent, if you use that term, in some villages and communities is far lower than 18. So some of these are girls and adolescents, but the risk to them is actually being monogamous with their husband because of sexual practices and the burden. And we know that of new cases in sub-Saharan Africa, 44% are in heterosexual couples. Still many among men who have sex with men, and some injection drug use, and in casual, you might euphemistically call heterosexual risk, but the majority are in heterosexual couples, many times married. And it's very common for a HIV serodiscordance to occur. And the risk of transmission among serodiscordant is about 14% in a year. So it's very high. So eventually, without an intervention, that seronegative partner will become HIV positive if we model it long enough. Obviously, counseling is needed, and certainly until really this year, you know, obviously among serodiscordant couples, their desire for children many times overstates their risk of acquiring the infection as a risk driver. And this isn't just, let's blame the people living in a village in Uganda, Kenya, or Tanzania. No, we see this in the US. I mean, and it's not based on socioeconomics. These desires, our sexual life, our life in wanting family, you know, they kind of trump a lot of what we might see here in an academic realm or from a dispassionate realm, logical behavior. So having kids is not logical. Based on that, Mike Cohn at UNC and others internationally developed this landmark study from the HIV Prevention Trials Network, go by the clever name of 052, which is really looking at immediate treatment for serodiscordant couples versus delayed. And here the delay meant was, you know, their CD4 count was quite a bit lower, usually under 350, and most of them were under 250. And you could see dramatically in following these folks, of the 1,700 plus serodiscordant couples, that those that got deferred, you know, more than 25% were of their seronegative partners became HIV positive. So immediate treatment was really a dramatic improvement. In fact, a 96% reduction in transmission. And of the transmissions in the immediate group, you know, most were the transmission wasn't with their partners' HIV, so there were other things going on. So we think the whole idea of treatment as prevention, this was really what made it the Science Journal Study of the Year in 2011. And really dramatic demonstration of the efficacy of treatment as prevention. And it didn't matter whether the serodiscordant partner was a male or female in this case. The other big thing that's happened was the FDA approved a co-formulated NRTI combination, namely tenofovir and emtricitabine, goes by the brand name of Truvada, as a once-a-day regimen as pre-exposure prophylaxis. This was FDA approved in the summer of 2012. So it's been a little over 3 years. 3.5 years. And really for initially men who have sex with men, high-risk heterosexual individuals, and injection drug users. Why this as PrEP to take daily as a prevention? Well, you know, this is a broad and potent regimen, very active against many subtypes of HIV, Very good safety profile in terms of side effects. There can be some, just like you know, there's some with Tylenol. So, but a very good safety profile, very easy to take, no food restrictions, few drug interactions, and randomized trials really show how surprisingly efficacious. And Ryan Westergaard, our colleague, went through some of this a few years ago when he did his grand rounds, but just to reiterate, a number of randomized controlled trials really showed that tenofovir, emtricitabine, co-formulated once a day pill, in that group dramatically reduced the acquisition of HIV from anywhere from 44 to 75% efficacy. In those trials that weren't efficacious or that had less efficacy, it really strongly correlates with drug levels of tenofovir and reported adherence to taking it. So if they take it, it's incredibly effective. If they don't, not so effective, which is really not a surprise, a very strong correlation. More recently, this past year, a number of studies have either been presented, some may be in press, the Kaiser study, but the others were really hot off the press within the last year, looking at PrEP, meaning this Truvada or tenofovir emtricitabine pill taken once a day in high-risk individuals in real-life settings. So as opposed to randomized trials. One was the PROUD study of 545 high-risk men who have sex with men in the UK, really showed dramatically reduced HIV acquisition rates by 86% over the projected rate of that group. Likewise, a US demonstration project of 557 men likewise showed reduced rates. A Kaiser study showed no infections of 657 people in San Francisco, where they expected about a 9% rate based on even STIs within that group. And then when a cost-effectiveness analysis on HIV prevention that was presented this past year really showed the affected cost savings of averting one HIV infection in the US is really about $230,000, and that doesn't really even account for like early, all of the comorbidities that an HIV patient could get. So this is probably an underrepresentation. However, not unlike antiretroviral therapy for a positive individual, there's a care cascade, and this was presented this past year of PrEP, of 562 men who have sex with men in the Atlanta area. Only about 50% at the time were aware of PrEP, and a smaller percentage on PrEP. And as you can see, of the folks that we might identify among a population being at high risk and eligible for PrEP, only about 15% in this care continuum or cascade are reaping the benefits of that. Future prevention, I'm not going to go into this, but these are actually very exciting in phase 3 trial. There's a PrEP impregnated vaginal ring that's being studied. There's long-term injections, meaning depots of antiretrovirals that can be injected for more than a month of coverage. Obviously, seems like a great option. There's rectal microbicides. We have vaginal microbicides. These are rectal to help with rectal or anal intercourse, and even episodic PrEP. We're not there yet, but the idea, can this be used as a weekend pill? Right now we would say no, because you really need stable levels, but studies are ongoing, and there was a big one studied in the New England Journal that showed there was efficacy, not as good as with a continuous PrEP, but if someone were getting 3 to 4 doses a week, they did probably pretty well. It's not a message we want to promulgate yet. So with the last few minutes, what are the scale-up strategies? We talked about the big advances that are even taking place now in the 20 teens. We're still making progress. And how do we scale this up? Well, Reuben Granite, a colleague who's at UCSF and had been at the World Health Organization, really was the main mover in bringing these test and treat approaches to our awareness. And this was all modeled based on a South African data of the epidemic there. And he basically hypothesized that, listen, if you treat everybody at that time and give them universal testing and immediate antiretroviral therapy, you're going to drop the incidence, prevalence, and mortality. And this seemed like, kind of a pipe dream in 2008 and 2009 when it entered press. Like, yeah, that's great, makes sense. But we're seeing this in real practice now. And he basically modeled that if we did that by 10 years, the incidence rate's going to drop to less than 1% in South Africa. Prevalence is going to drop to less than 1%. And by 2032, this is going to be cost savings. We're really taking those strategies on now. And the World Health Organization has really bought into this. This is again modeled from 2015, but really now the status quo of treating folks, if there's access, and this is global information, not just the US, but if there's access to care, if they have the right antiretroviral therapy, if their CD4 count is lower, that's not going to fly anymore. And fortunately, that benchmark has been changed for our global rollout. Now it's not just that, it's not just universal antiretrovirals when CD4 drops. It's not just circumcision, which is actually highly effective in low and middle income countries in affecting transmission to men. Does nothing for the woman, but it's good for the men. But early antiretrovirals and PrEP are now on the docket, not just in the US. This is really global. So what are we doing in the US with that? Well, actually, almost 2 years ago, Andrew Cuomo, the governor of New York, really said this was landmark, ending AIDS epidemic in New York State. He stated this publicly. They wanted to get down new infections from 3,000 to just under 750 by 2020. And this was a monumental public policy and political statement. And it was three-pronged approach, not surprising, fairly intuitive: identify undiagnosed, link them to care, retain them in care, ensure they're getting vaccinable suppression, and provide PrEP for high-risk individuals. How have they done? Incredibly well. In fact, this is obviously not a trial, this is real-life data. We can see that the number of total HIV diagnoses in a year has dropped in the teens. Women with HIV has dropped, and heterosexually transmitted diagnoses have dropped. In fact, of that group, a 52% drop in the last 8 years. Pregnancy rates, there's trickle-down benefit, or not trickle-down, real benefit, like teen pregnancy rates are also dropping when they have these kinds of public health messages. What do we see even before that in resource low-income countries like Cambodia, Malawi, South Africa? We're getting, with their rollout efforts, and it's not usually just getting the antiretroviral, it's getting them to the individual, keeping them in care. They're having incredibly high rates of ART access. In Cambodia, they say that 90% of those folks eligible based on their criteria are getting antiretroviral therapy. This is, not molecular biology here, but incredible implementation efforts. And we see the advantages. Death rates are dropping throughout Africa. We saw survival from cradle to grave really improved during the 70s and 80s, about in Africa until about 1985. Then it's been plummeting. Now it's coming back. And as I said, this has been a landmark, this 15 by 15. Now we're up to 16 million people internationally on antiretrovirals. That's really a landmark. What has this meant? 41% of all people are assessing treatment, probably higher today, compared to 23% 6 years ago. And children are getting treatment. Pregnant women are getting much more treatment, and we're seeing a drop in mother-to-child transmission. It's not perfect, but we're seeing this drop. We got a ways to go, obviously. This just shows of the folks in sub-Saharan Africa that are getting treatment, it's only about 56% that are eligible. Now, that was on the previous guidelines. Today, it's even higher based on the fact that now we're going to treat everybody regardless of CD4 count. There is no CD4 count. We'll have to see. So this differential is going to get larger, but we're going to get more people on treatment. And there are, there's new initiatives that come out. Now we're past the 15 by 50. Now there's 90, 90, 90, and 95, 95, 95. These are all pipe dreams, meaning let's diagnose 90% of the people, get 90% on treatment and suppressed. But we're heading there. We're not, I'll tell you, Cambodia is going to do it before we are in the United States. But you got to set these targets to achieve anything. So the projected future is not inevitable. Can we get to zero? I think so. It's going to take a while. We've already known HIV for over 30 years. And death rate, new infections have dropped dramatically in the last decade. Doesn't feel like it, but it has. AIDS deaths have dropped dramatically. We still have room to go. Mother-to-child transmission is preventable. In the U.S., it's rare. When it happens in the U.S., it's a real failure of the healthcare delivery system, not the antiviral or biomedical kinds of approaches. There's tons of good options, and we're expecting people to live at least 3, 4, 5 decades with HIV today, depending on their age. Prevention works in low, middle, and high income. Universal testing, obviously a crucial step. Can't all be done in ID clinic, as you know. And real-world PrEP studies show how effective it is, and treatment's now indicated for all. So I'm going to stop here. My last acknowledgement is these are all the people that I work with regularly: faculty, staff, support people, administrative folks. We have probably about 45 people that have an active role in the HIV clinical venture, and we got most of them on some sort of external funding, and couldn't do it without them, and thank you for your time.
Great talk, Jim. It's amazing what's happened with prevention and treatment really in a short time. I think we have time for one question. You get to be the chooser and repeat the question.
I'm sorry, one question. And it's got to come from Bennett. Thank you, Bennett.
So that remarkable drop between those who are known to be positive and engagement, and have we really sorted out as a nation what this is? Is it lack of access to or effective mental health care, substance abuse care, having a home, or just a lack of homophily between those who have HIV and the ethnicity of those who care for individuals with HIV? Do we know what is dropping it from 80% to 40% so we can make a change?
Bennett's very thoughtful question was that gap, that 40% drop off between knowing your infection, engaging and re-engaging in care in the U.S., which really is an embarrassment compared to the rest of the world. Do we know more about it? Is it just injection drug use, mental health, other addiction, ethnicity? The short answer is yes to all of the above. But it's surprising how, the new watchword, so I'm going to kind of end around this a little bit. The new watchword about a culture of health, unrelated to HIV, this is kind of what we're hearing in the press, we're hearing from the CDC and Public Health Service, just in general, for U.S. healthcare goals, this idea of the culture of health. We really have to, some of it's related to that, meaning we've brought many folks to public insurance in the last few years with the ACA or Obamacare rollout. But these are adults, some very smart, and many have never had insurance, and it's amazing the barriers for them to even want to use that insurance or how to use insurance. They need a course 101 or 201 in how to be a healthcare insured individual. That's not trivial. We've had folks that do not have mental health issues, that do not have injection drug use, that have resource. They might lose their job or be in transition, and they don't want to let us know because they're embarrassed, and they fall out of care for 2 years. And we have federal grants and resources to cover them, and so there's no cost, but they don't want it. This isn't you wouldn't classify that as a mental health issue, but it's an issue about our American culture of care, and we see it very poignantly in HIV because we're trying to engage everybody in care. If someone with hypertension doesn't show up in primary care clinic, we may or may not engage them in care. I don't say we don't try to, but in HIV we have all of these other people trying to, so we hear some of these stories. So the long part of it is, of my answer to what you said, Bennett, is yes, it is those, but yes, there are other issues that are making it really a daunting challenge in the U.S.
Thank you. And people can come up and talk to Jim after with other questions.
Great, thank you.